Hi, good afternoon. So I am doing a video presentation of abscess, incision, and drainage. Abscess is accumulation of pus surrounding tissue. It can be associated with cellulitis as abscess alone. Normally, it can be found in groin, in the breast, neck, extremities, in the buttocks, where normally friction is. So it's indicative to have I&D or incision of drainage if it's greater than or equal to 5 millimeters, if it can be palpable, and if it doesn't resolve despite doing conservative methods or measures. There are the reason for doing I&D is to relieve pain. It's a method of draining abscess and for quick recovery. In doing this procedure, normally we do this in emergency, in primary care, and in order for an aspiring nurse practitioner, it is best that we know how to do it. First is to prepare the equipment needed. What we need is the syringe. So here it is. So I prepared it. We'll be needing the hemostat clamp, the blade, which is normally can be 11 or 15, the gauze, the needle that we'll be using for anesthetic. We could the swab used for culture sensitivity for cleaning purposes, and drape. We want it as much as possible to be clean or sterile, or clean at least. And we also need the scissors, and we also need the iodide form for packing. So in this scenario, we prepared a from the patient, telling the risks and benefits of the procedure that we're gonna do. We there will be they can expect some pain, some swelling, and some scars from the incision site. So we go ahead and proceed with our patient. So we want to drape the area, and then we position our patient. Meet Mr. Chicken. So this is our patient. So we reposition the patient. And we make sure that it's clean to prevent any complications or um, microorganisms that may infect the area. So what we want is to clean the surface of the incision site where we want it. We can clean it with chlorhexidine or betadine, inner to outer, circular motions. Wide, we want it wide and the wide area as well. All right, so we go ahead and numbed the patients for comfort. We don't want the patient feeling any pain. So what we want is to use 1% lidocaine or lidocaine with epinephrine. This duo uh, makes the patient numbed and at the same time stop from bleeding. We want to inject the wound parallel to the skin injection site. In a intradermal tissue, we're putting it entire on the entire needle. So we're doing it on a, so the goal is for the infiltration. We want the medication to infiltrate, to spread, so that the patient won't feel it. Also, we have to take note that the abscess itself is acidic. So in that case, the it's acidic, so it loses the effect, the anesthesia effect of the medication. So we want to wait for a little minute, for quite a while, like 5 minutes, or we could give an adequate amount of the anesthesia for so that we could begin. So we were gonna try to press it gently, and you will notice we might notice some blanching. So that's an indication that the medication is spread out already. So After 5 minutes, let's say Mr. Chicken is ready and not feeling anything, we could check it. He might feel some pressure but not sharp pain, so we're good to go. We will gonna start with our scalpel. Scalpel, we want to go on the center going outward. We hold scalpel between our thumb and the finger directly on the pressure site. We might feel some pressure. Some says that, or they said that they want to do it parallel to the existing skin to prevent the tension and also for cosmetic results. So we do a start with on the center going just enough. We don't want it. We just want it to be gentle. You're gonna feel a little bit pressure as the yeah, as it oozed some drainage on it. We just want enough where our hemostat can come in or can go inside, but enough not to perforate the back of the wound. And then this is a good opportunity for us as well to get some sample. What we want is for it to be a little bigger. Okay, and then we get some sample, and then we can send it in the lab. Routine culture and antibiotic, they said it's not normally necessary if the drainage is done properly. So we go ahead and we send it to the laboratory. Okay, somebody will gonna run and send it to the laboratory. We can do manual gently pressing on our site. Gently press on it to make sure that that abscess is going. We do gently pressing. And then again, we can do again another place our hemostat inside and around the surrounding to make sure further blunt is completely dissected. So this will allow to open the locolation. So we do it again, manual. We do fraction, gently pressing it, gently expressed. And then we could also do some after doing this, and we are sure that we were able to break all the locolation inside by using our hemostat. Not too much because we don't want perforation, just enough. So we're good if we don't see any more. And then we could flush it with a normal saline, or we could use the splash solution. So pretending I do have that because I don't have it right now, we do splash it with a normal saline. This will help in cleaning, and it helps prevent buildup of pressures. So where we're good to go, when we see it's clear, the come out, it's coming out clear, then we are good to do packing. Wood packing, we could start with 1/2 inch with strips. This one, and then we check just enough. We don't want to overpack. To overpack it as well. This allows for secondary, just enough will allow us for secondary intention, healing, and it avoids premature closure of the wound, which can lead to reaccumulations of the bacteria or the abscess. Also, the primary causing agent for abscess are Staphylococcus and Streptococcus. But for perianal, sometimes it's the enteric coli. So just enough. Overpacking, it can cause necrotic to the site. We don't want that happen. So we go ahead, and then if it's enough, we have put enough, we could cut it. If you feel it's enough, we can cut it with scissor. Just enough for a tail, see a tail on it, because in like 2 to 3 days we're gonna remove it and check if it needs to be repacked or normal healing will happen. So complication, patient might experience pain, reoccurrence of abscess formation. What we don't want is septic thrombophlebitis, fistula formation, scarring, necrotic fasciitis, or damage to the nerve cells. We are gonna close it with a gauze. So we could also provide the patient with written instruction on how they're gonna do it at home. If it's soiled, they could just do this, repack it, and if they're not in a soiled area, they could just leave it in open air. We make sure that their tetanus is updated, and we're gonna follow up with the patient 2 to 3 days so that we could visually check it on how is it. So we don't want, so that's how we do dilatation, incision and drainage for an abscess. So I can't find the thing to put the thing. Okay. Oh shit. Sorry. It's that doesn't allow me. So if the patient generated, as I mentioned, a progression of cellulitis or a development of fever or any signs of infection, then we could go ahead and check for the result of the results of our culture and sensitivity to see what is best antibiotic that we could give to the patient. So if it's not healing or anything, we give them. I'm gonna show you Mr. Chicken's end product. Right. Okay, so he's good to go now. We'll see you in 2 days, 2 to 3 days for follow-up, Mr. Chicken, okay? That's about it.